malnutrition or malnutrition in hospitalized adult patients, and specifically trying to provide you with a South African perspective. So you probably know, but just to put the program in context, I will start by trying to convince you that we do have a problem with adult hospital malnutrition, and trying to convince you, as I said, why we actually need to act now. And then this will be followed by two presentations, both by colleagues of ours, Janneke Visser and Esmerie van Tonder. Both of them worked on this field for their PhDs respectively. Janneke will talk to us about the barriers and enablers in trying to manage adult hospital malnutrition, and Esmerie will talk about some validation studies to try and find surrogate tools that we can use to help us in the assessment of the malnutrition. And during my first presentation, I will sort of try and also indicate you to show where both of the next two talks will fit into the bigger picture. So we've allocated 20 minutes for each of the presentations, and then thereafter we've got some question time. So I'm not going to allow question times in between. Please keep a note if you have any questions as we move along, and we will definitely try and keep in the time frame. But we really hope this will elicit some discussion. So if I start with the first bit in terms of why do we need to act now? And for those of you that heard me talk about this topic before will know this slide so well. And the reason why I always start with this slide that indicates the prevalence of malnutrition is actually to show that it is all over. This slide indicates various tools that have been used to diagnose malnutrition, various countries at the x-axis, South Africa not being on the map, as it were, in this specific slide. But basically what you'll see is that between 20% and about 60%, that's where the majority of the prevalence data seem to be. What is the situation currently and locally in South Africa? Well, I'll share with you results of 3 studies that we have done that I can give you some data on. The first one was this study that was conducted already in 2016, 2017, and we included 3 hospitals in South Africa, 2 in Kenya and 1 in Ghana, and the idea was to use a standardized approach to determine the prevalence of at-risk for malnutrition on admission to the hospital. We used the NRS 2002 as our screening tool, and just over 2,000 patients were included in the study. And as you can see here, as on admission, pretty much 2/3 of the patients, 73% of the patients, were already at risk to develop malnutrition. If you can maybe see the detail on this slide, this hospital A is Tygerberg Hospital, and you'll see that it was 68%. So we really have a huge problem even in our own backyard. What probably is even more concerning is the next figure, and that is that 1/5 of those patients, 19%, were referred for nutrition support and monitoring. We did a similar survey earlier this year, again, only in Tygerberg Hospital, much smaller sample size, but again, we used the NRS 2002 screening tool, and we got an at-risk for malnutrition on admission prevalence of 60%. So yes, we really do have a problem. Data that Esmerie will also talk a little bit more about is that in her study, which was done in the Eastern Cape province, combination of public hospitals as well as private hospitals. Esmerie used a different tool. She used the MUST as the screening tool, but with her tool, at risk for malnutrition, 73%. So again, very much in line with the data and the figures that I've shown you from the other sites. She also conducted or went further and also determined malnutrition per se, and the detail of all of this I'll talk to in my presentation. And of those 73% of patients at risk, 54%, basically half, all the patients in the hospitals were malnourished. Again, a similar number of patients were referred for, or not referred, for nutrition support. So part of Janneke's PhD was to conduct a scoping review to try and determine what is the prevalence of malnutrition on the African continent. So I just note that there are some problems with people saying that they can't see the slides. Can I just get confirmation from the others that it is visible?
I can see it, Prof. Lau.
Okay, perfect. Thank you so much. So on this scoping review, which was done on the African continent, again, you will see that the prevalence rates varied very much. For at risk, it varied between 23 and 74%, and for malnutrition from 8 to 85%. So again, huge differences. And I'm referring you back to that very first slide with all the dots and the crosses, which indicated that everything is all over the show. And the reason for that is that people use different tools. And sometimes they use the tools incorrectly. And Janneke will most likely also refer to that in her presentation. So in order to try and get consensus and in order to try and get standardization, that is basically what we are all busy with, because how difficult is it to compare 8% to 85%, and which one of those values should I then actually believe? What we do know, though, is that hospital malnutrition is associated with a host of negative complications or consequences. There's increased risk for developing infections and complications. There's an increased length of stay, more readmissions and frequent readmissions, an increased reliance on others. So even if they do go home, they need support, they need care, they are not self-sufficient. And obviously an increase in mortality, and all of this adds to cost. So all of these things do tell us that we need to act sooner rather than later to try and break the cycle if we want to address the problem. I'm talking about hospital malnutrition, but remember, these patients come from home, and the moment they go back home, they go back into the community. So even though the assessment was done in hospital, this is actually a reflection of the community-based malnutrition prevalence that we are faced with in the country. So in order to try and address the problem, there is a process of nutritional care. Now, this comes from a document which was a joint fact sheet statement from the WHO as well as ESPEN, which is the European Society for Clinical Nutrition and Metabolism. And they brought out a position statement on disease-related malnutrition end of last year. And it's in line with the processes of nutrition care, which means that there are 4 main steps in assessing any patient. The one is the screening part. We need to have some form of proper screening in place to identify at-risk candidates. We then need to have a standard diagnostic tools in place and apply it consistently. Then the third phase is to plan and to implement the management, the treatment, and then lastly, the monitoring and evaluation. And this afternoon, I think specifically also with Janneke's talk, she will touch on barriers and enablers across the scope of these 4 stages, whereas Esmery will probably more focus on the screening and also specifically the diagnostic section, where we are trying to look at some surrogate valid measurements that can be used. So I'm not sure how many of you are familiar with this international declaration on the human right to nutritional care. This was signed by 75 societies from across the globe already in September of 2002. South Africa, one of them that supported or signed this human rights declaration. And this declaration states that the right to nutrition care is integral in the middle between the right to food and the right to health, which are part of our constitution. So the right to receiving the right food, the right to be fed, the right to be screened, diagnosed, and properly managed. This is what this human right for nutritional care talks to and refers to. And that is respecting the dignity of this patient that's malnourished. And I know this is very small, but I'll read you through the highlights from this document, the consensus document on this human rights to nutrition care. It says that it's the right to benefit from the whole process. That takes into consideration the right to be screened, the right to be diagnosed for disease-related malnutrition, the right to receive a regular hospital diet or a therapeutic diet, whatever is needed. It needs to be administered by an interdisciplinary team of experts, and the government has a duty to guarantee it. So it's the whole cycle and the whole process that our patients have a right to. And in order to to fulfill this right, in order to implement this right, there are some mandatory actions, which again it's a repeat, but the actions are nutrition screening, on admission to hospital, or if it's a primary care, first contact session, diagnosis and assessment of malnutrition, and then regular monitoring of the care plan, whether it's oral nutrition or therapeutic nutrition, that doesn't matter. So all of these various steps come into play in this nutritional care as a human right. So the last little bit of my presentation is just to talk you now through a standardized approach to identify and to diagnose malnutrition. So the Global Leadership Initiative on Malnutrition, we refer to the GLIM group, came up with a consensus report for the definition, the standardized definition of malnutrition across the globe in adult hospitalized patients. And it is a stepwise approach. So the first step is that all patients should be screened, and I've just alluded to that as part also as the human right. So all patients should be screened, and currently the tools that are recommended for screening can either be the MUST, the Malnutrition Universal Screening Tool, or the NRS 2002, which is the Nutritional Risk Screening Tool, or for the elderly patients, the Mini Nutritional Assessment, or the MNA. So there is a working group from GLIM that's working on coming up with more refined recommendations for screening, but currently these are the tools. So you can choose which one works for your environment, and you'll note that from the studies that I've alluded to at the beginning, we used NRS 2002, ESMRI, for instance, used MUST, but it's all part of the recommended tools. But the next step is that all those patients that are then identified as at risk should then undergo a full nutritional screening process. And according to the GLIM approach, that consists of 5 steps. 3 of them are etiological criteria, which is weight loss, body mass index, and an assessment of muscle mass. And 2 of them talk to etiological criteria, which refers to a decreased dietary intake or assimilation and inflammation. Now, for each of these groupings, the phenotypic or the etiological criteria, there are cutoffs, and that's not important for this talk. If you are interested in this, you can read the cutoffs and you can work according to that. However, and Janneke will talk to this and Esmery will take it further, a lot of the potential barriers, or I can say excuses, for not screening and not diagnosing malnutrition is that people say, well, we don't have scales, we don't have stadiometers, we don't know how to calculate a BMI, we don't have ultrasound, so we can't determine muscle mass. So excuses of not having the necessary tools and toys and equipment and skills in order to perform these assessments, and therefore it is not done. So Esmery will show you that she has worked on surrogate measures, easy to perform surrogate measures that can be used in lieu of any of these in order to come up with the necessary answer to perform this. So the GLIM criteria is you need to perform all 5 of these categories, and then 1 positive in the phenotypic category and 1 positive in the etiological category means then the diagnosis of malnutrition is made. The next step is then all those that are diagnosed as malnourished then needs to undergo a severity grading and a diagnostic category. So the purpose of the severity grading is basically just using the phenotypic criteria and again with various cutoffs to determine whether it's moderate or severe malnutrition. This has to do with the ICD-10 coding and a lot of the reimbursements across the globe, but it's also important obviously to see with monitoring if my patient actually improves. And then the last one is the etiological or the diagnostic category, which pretty much refers us back to the underlying problem. What do we have to try and treat or prevent in order to break this whole cycle? So there are 3 categories in terms of adult malnutrition. The first one is malnutrition without disease. So this is pretty much your malnutrition because of starvation or poor socioeconomic status, depression, emotional struggles, poor oral health, etc. So a person just having inability to have enough food or consume enough food and therefore develop malnutrition, but no underlying disease. Whereas the second grouping is disease-related malnutrition with 2 subcategories. So disease-related malnutrition with inflammation or disease-related malnutrition without inflammation. So in this group, it is the disease that results in the malnutrition or the consequences. So it's either the inflammation because of the disease and or the lack of intake or utilization of nutrients because of the disease that results in weight loss, loss of skeletal muscle mass, physical and mental dysfunctions, and a worse outcome. But you can understand that it is important to try and pinpoint the underlying cause in order to adequately and properly manage this. So therefore, my pretty much last slide is then to refer you, just for you to remember, we've got this whole scope. We have to identify our clients by screening. We then have proper tools in order to do a good diagnostic assessment. We then implement our appropriate management, whatever that requires, but continuously we have to monitor and evaluate and go on with the cycle in order to effectively manage our clients. And with that, I want to thank you, and I'm going to stop sharing, and then while I introduce Janneke to upload her slides. So Janneke Visser is a senior lecturer in the Division of Human Nutrition here at Stellenbosch University. And as I've mentioned, the topic that she will be talking about is barriers and enablers to the management of adult hospital malnutrition in the local setting. Thank you, Janneke. You can see your slides, but it's not on presenter view. There we go.
Is that okay? Is that okay?
Yes,
great.
perfectly. You can go. Thanks, Jan. Thank you.
Okay. Good afternoon, everyone. I'm happy to be here this afternoon to share with you some thoughts on this important topic. So thank you to Professor Blau for highlighting the importance of adult hospital malnutrition. And my talk will now follow on that very brief talk, focusing on the barriers and enablers to address this important problem in the local setting specifically. So identifying preventable barriers to optimize nutrition support is extremely important if you want to address hospital malnutrition effectively. And these barriers have been described in the literature. And although some are relevant to many settings, it is important to actually look at specific barriers in specific settings. And these barriers and enablers will depend on the setting that you're working in. So whether you're working in a public setting or a private hospital, or different levels of hospital, that will also have an effect on the specific positives and potential challenges that you will face in your specific setting. So we do have international studies that give us an idea of some of these challenges and also facilitators, but we also need local context. We need to look at local studies, what is happening, what are the challenges that we face in the local setting. So it is important to identify these specific factors to be able to put strategies in place to address this effectively. So while there's great overlap with the enablers and barriers that we find in the international literature, I think everyone that works in the local setting will know that there are specific factors that are more uniquely, I would say, South African or African things or challenges that's more pronounced in the local setting. And we need to take that into account when we plan our strategies and our implementation actions that we want to take. So the data that I'm briefly going to report on was part of a larger adult hospital malnutrition study that had a multi-stage mixed methods framework. And this study had 3 phases. And I'm just going to briefly report some of the findings of phase 2 of the study that included an electronic survey that went out to all hospital dietitians in the Western Cape province of South Africa. Parts of the study also had a Western Cape focus. And then we also had several semi-structured interviews with selected role players. And importantly, these role players included not only dietitians, but also medical doctors, nurses, managers to give us a broader perspective of the issues at hand. And then the final phase of the study included a Delphi process where we had an expert panel, also with people from different backgrounds to give us a broader perspective again. And this panel actually considered all the findings of the study and put forward consensus strategies with practical suggestions in terms of how to address adult hospital malnutrition in the local setting. So in terms of data analysis, we analyzed the quantitative and qual data separately, but we ensured meta-integration of the data when we reported the findings and also when we interpreted the data. So just as a little bit of a background perspective, I'm not going to report on this specifically today, but if we look at South African studies, the ones that we do now have available, and we're building that evidence base, from the studies that we do have, and Renee also alluded to this, we know that in our hospitals, limited nutritional screening is taking place and also assessment linked to that. Generally, people report poor referral practices, and overall, there's this limited awareness of the importance and possible benefit of addressing adult hospital malnutrition. So against that background, I now want to get to the enablers and barriers that we identified in the broader study. So on the screen, very busy slides, but you can see in the green table, we've got the different enablers, just briefly summarized, that we identified in the study. And in the gold table, you can see the different barriers that we identified. So in this study, there was strong agreement between the survey and the interview findings in terms of the specific factors that we identified. And you can see this in the table because between the different columns, you can see there are very similar factors that were highlighted. And also interesting, I think, to note is that sometimes some of the key themes that emerged as enablers in certain settings were conversely identified as barriers in other settings. So many of these factors can be either an enabler or a barrier. For the rest of the presentation, I want to highlight the fact that in the study, we identified a lot of positives. So there's a lot of positive things that we can take from this. A lot of people indicated a lot of enablers and facilitators. But for the sake of time, I'm just going to focus on a few barriers, challenges that we identified in the last few slides. So first of all, I think we all would realize this, and this is an obvious one, is of course resources. So in many of the settings, human resources, staff shortages were identified as a major barrier. And a lot of people felt that staff were overburdened already. And there was this feeling that there's fewer hands available for various nutrition support endeavors and activities. There were also quite a few differences between our tertiary hospitals, for example, and our district hospitals, with the tertiary hospitals sometimes reporting better staffing. And then the district hospitals, the interviews I had there, a lot of the dietitians indicated that they were the only dietitian responsible for various facilities and hospitals, of course, which makes it very challenging to implement some of the strategies that we have in mind. To further build on the resources, unfortunately, always finances play a role. So restricted budgets, and beyond the staff component, some comments came back about the availability of nutritional products that is available to manage our patients. And there was again this feeling that often we have to compromise in terms of how we care for our patients because of budgets and also lack of available products specifically. And then Renee also referred to the tools. So some of the settings reported there's just a lack of tools, or the tools that are available are not working. And I'm referring here to very basic tools like scales and stadiometers, not even the fancy equipment that we can use in this setting. And then also lack of equipment in some settings to administer enteral feeds, which then limit your options that you have available to support your patient. Another thing that came out, and this Renee also alluded to, was a lot of barriers when it comes to screening and referral practices. So as we already mentioned, limited nutrition screening taking place. There's a lack of a standardized tool. Also, what came out in the study that we're not going to focus on now is that some people also use these tools incorrectly and do not always understand there's this difference between malnutrition risk and malnutrition diagnosis, for example. And then also the perception that only the dietitian can do screening, although we know that this can be performed by any healthcare professional in any setting. Some of the practical things, I'm not going to go through all of them, but often people reported that even basic parameters are not available to use in these screening tools. Often patients are not weighed. A lot of people said you're very lucky if you find a height measurement in a file. And there were also practical things, simple things like not being able to calculate BMI by some healthcare professionals. And then things like patient mobility. What do you do if the patient is bedridden? How do you estimate height and things like that to use and to plug into your screening tools? And then in general, poor referral practices. Interestingly, there was this notion that a lot of people said that they feel the younger generation of healthcare professionals are a bit more aware of the possible benefits of nutrition support and are more likely to refer versus, for example, some of the older practitioners. So lack of referrals, late referrals, misreferrals were all highlighted as barriers that should be improved when we implement strategies and plans to make the process better. A key thing that did come out in the study was the whole concept of role player buy-in. And this came out in our survey and basically in all the interviews that we did. And that is that support for any endeavors and strategies need to come from the top. So engagement of hospital management, you need buy-in from the powers that be, also other healthcare professionals, also getting Department of Health involved. Our little group have already started by reaching out, having small meetings and trying to get the conversation going regarding how we can address the specific problem. Then, of course, awareness. Like we said earlier, there's a general lack of awareness of what it entails. This is not only healthcare professionals, but also hospital management. And this is where the whole thing comes in about training, education, and various factors like that. And then a lot of the dietitians said that visibility is important. They felt that we need to be out there, we need to be visible in terms of what we do, we need to be vocal in terms of raising awareness about the specific issue. And then, of course, attitudes will play a role. If you have to deal with negative attitudes or don't care attitudes, or some people indicated that in some facilities there's a general lack of respect for the dietitian, that is going to be challenges. I just wanted to highlight here as well that in many of the facilities that we went to, that we talked to, there was also, this was sometimes listed as a positive, an enabler. So a lot of positive attitudes in some settings, that is a good basis to work from that you can build your strategies on. So not just all doom and gloom, but negatives and positives. Then collaboration. Lack of collaboration. We still find that healthcare professionals work often in silos. And especially our private practicing dietitians indicated that they sometimes feel isolated. Everyone is doing their own thing. There's a lack of a team approach. So that was also considered to be a barrier. And then another big thing that came out of the study was the whole challenges surrounding medical aid and some of them not supporting nutritional interventions, or they're not considering nutrition support a priority. So this was one of the key things that came out, that we need to engage with these medical aids more. We're already doing so, but we need to do more in terms of getting them on board to support dietetic practices. And then also late referrals, private, when limited funds are available, are also considered to be an issue. And then a few things about stock limitations. Many of the settings indicated that things like tender and budget constraints make it difficult. A lot of things that came up were related to the supply chain, products not being delivered, not being ordered correctly, simply not being available, for example, and then different types of products available in different settings. So basic versus no products being available versus, for example, having specialized products available. And a lot of dietitians actually said that in practice, they often have to improvise with what you have, making it difficult to optimally support your patient in practice. Then food services remain a very important part of the whole process, and also food and product delivery. I'm not going to go through all of this, but basically practical things like settings where there is no therapeutic diets available or very limited therapeutic diets, so no diabetic diet or renal diet available. And then also practical things like food being removed before charting or before consumption. The patient is away for a test, or for example, they needed assistance, but nobody was available to help them, for example. And then also things like diets and supplements and enteral feeds, either not reaching the patient or not reaching the right patient, and then related wasting in terms of that specific practice. And then just basically very briefly, a lack of education and training. So this is at undergrad level, also postgrad level, also at in-service level, lack of understanding, time, lack of skills, and lack of advocacy. a lot of the people indicated that in places where there were nutrition teams in place or a nutrition champion or leader, they found that to be an enabler to address the specific issue. And then there's this perceived lack of local data, although we are building the evidence base. And here I wanted to mention that a lot of the participants actually said that when they go to a hospital management meeting, or if they get a chance to speak to this, a lot of these powers that be do want to see local data and not just international data. So luckily, we are building that evidence base as we do the various studies. Last two slides, just to give you an idea, from the study, this expert panel that I mentioned previously via a Delphi process then took all of the information findings from the study and they put together 38 key strategies that they thought would be important to address adult hospital malnutrition. And from that, they prioritized 8 strategies under 4 key themes as a starting point to take this further. And just to give you an idea, without going into too much detail, the 4 key themes that were identified as a starting point were related to awareness. People need to be aware of the problem to actually address it. And this was healthcare professionals and also hospital management. And then focusing on nutritional screening that Renee also mentioned is going to be important. We need to identify those that need support. And there they talked about things like mandatory screening, having it part of the admissions process, for example, and then good referral practices and protocols. And then again, the key thing about the medical aids and getting them on board to support nutrition support endeavors and practices. So in conclusion, in this study and in other local studies, we're starting to build a base in terms of enablers and barriers to address adult hospital malnutrition. And it gives us insight into the positive things, the facilitators, but also the problem areas that need attention. I feel very strongly we need to identify what is relevant for our setting, and we need to address it systematically. We can't implement all of the 38 strategies immediately. We need to decide where we're going to start, and we need to do it systematically, and we've started with that. And these barriers and enablers are going to differ among settings, and we need to consider them in context when we design our plans and strategies. Thank you so much.
Thank you, Janneke. Appreciate it. I'm pretty sure there will be some comments and questions from the colleagues, especially those also that participated in your study and in this survey. Esmery, if you can please share your slides and then I'll introduce you. So Esmery van Tonder is a lecturer from the Department of Human Nutrition and Dietetics, Faculty of Health Sciences at the Nelson Mandela University. And Esmery conducted the study as part of a PhD to determine some valid surrogate measurements that can be used into the GLIM criteria. So we're looking forward to your presentation and we can see your slides. Thanks, Esmery.
Thank you, Prof. I'm just going to try and put my camera on. Okay. Can you see me?
Yes, perfect. Thank you.
Okay. Okay, so thank you for the introduction and the opportunity to present my research today to you. As Prof. Flowers mentioned, we'll focus on the validation of surrogate tools to use within this GLIM criteria previously explained. So just a bit of background, and which brought me to the aim of this study. So as Prof. Blau clearly indicated in her presentation, from the studies that we have available in South Africa, it all points towards a high prevalence of malnutrition. However, it remains largely undetected and therefore untreated. And as we also know, malnutrition is associated with worse clinical outcomes for the patients and also an increased cost for the institutions and the medical aids. Janneke in her presentation highlighted many of the barriers related to malnutrition, including those of screening and diagnosis. And with regards to the relevant aspects of that for my presentation, or especially those that the parameters that's needed for screening and diagnosis of malnutrition, such as obtaining the BMI, percentage weight loss, a low muscle mass. And therefore, this study aims to assess the relative validity of surrogate measures when substituting the accepted parameters required within the GLIM phenotypic criteria. So ultimately, the goal to enhance the feasibility for implementation in resource-limited settings. So the study objectives included to determine the proportion of participants identified as malnourished according to the GLIM criteria, to determine how many of those that malnourished were referred to the dietitian, and then to determine the relative validity of MOAC and calf circumference as surrogate measures of a low appendicular skeletal muscle mass, which I will hereafter just refer to as a low muscle mass, which was determined by bioelectrical impedance, to determine the relative validity of MOAC as a surrogate measure of BMI, and lastly, to evaluate the relative validity of individual surrogates of the GLIM phenotypic criteria in the diagnosis of adult malnutrition. So just a bit of background on the methodology, which was quite an important component of this study. It was a diagnostic accuracy study. It included 5 hospitals in the Eastern Cape, 3 from the public sector and 2 from the private sector. Patients were stratified according to gender as well as national usage of the public and private sector. 3 trained dietitians collected the data between March 2020 and February 2022. As you can see, this happened during COVID, so we lost about a year of data collection. And then MUST was used to identify the patients at risk of malnutrition, and we used a MUST score of 1 or more that indicated increased risk. And then malnutrition diagnosis was used to diagnose malnutrition. And here, all 5 components of the GLIM was used. On the right here, you can see it's an extract from one of the GLIM working papers on identification of low muscle mass. At the top there, you can see the 5 GLIM criteria, which Frau talked us through, the 3 phenotypic criteria and the 2 etiological criteria. But I want to highlight the ones that I've investigated for potential surrogates, and that included a low BMI and a low muscle mass. So in the study, as mentioned, we did use BIA to determine measured low muscle mass, but then the surrogate that we've used was calf circumference and mid-upper arm circumference for a low muscle mass as an alternative, and then also MOAC as an alternative for a low BMI. With regards to inflammatory markers, we use that to determine the presence of inflammation, which is part of your etiological criteria. And there we've used an increased CRP, white cell count, or increased body temperature. And this is just the conceptual framework of the study that was done. On your left, you can see the diagnostic framework, including your first step of screening, and then your etiological criteria, which was done according to the proposed methods, and then your phenotypic criteria. I highlight there in the light orange color the surrogate that was used for the to replace the originally proposed parameters as explained in the previous slide. But then I also want to just take it a bit further. Once you have your diagnosis of malnutrition, we then also compared the how once you've plugged in the surrogates within the GLIM criteria, how does that compare in diagnosing malnutrition compared to using the original proposed criteria? And just with regards to calf circumference, I would just like to highlight here that we did follow the guidelines from Gonzalez et al. To adjust the BMI in individuals that is overweight or obese to minimize the confounding effect of adiposity on calf circumference as an indicator of muscle mass. So we've done the subtractions as indicated there for patients with a BMI above 25, and the more overweight or obese they are, the more we took off, so that can be a more accurate indicator of the muscle mass component of the measurement. In terms of statistics, just specifically referring to those that was used in the validation compartment of the study. Firstly, we used Pearson correlation just to determine the correlation between the variables under investigation. So, for instance, between the measured low muscle mass determined by bioelectrical impedance compared to the surrogate measures such as MOAC or calf circumference. Then we determined the diagnostic accuracy of the surrogates with the area under the ROC curve, where it was compared to that of the measured original proposed parameters, such as your low muscle mass. Then Uden's index was used to determine the optimal cutoff for each surrogate investigated, which was based on the best combination of sensitivity and specificity. And yeah, then for validation statistics, we then looked at sensitivity, specificity, predicted positive values and negative values for each of the surrogates. And then finally, we used Cohen's kappa to determine the level of agreement between the original proposed GLIM criteria compared to the GLIM criteria with the use of surrogates. So then moving on to the results, a total of 696 patients were approached, 216 were excluded based on either not meeting the inclusion criteria, meeting some of the exclusion criteria, or not willing to participate. So that left us with 480 patients that we screened with a MUST tool. 73% of those patients were at increased risk for malnutrition, and that was 350 patients, which then formed the final study population on which the full GLIM diagnostic assessment was conducted. The mean age of the study was 47 years. It's a relatively young group, but this is comparable to previous similar studies that was done in South Africa. As mentioned, we've stratified patients according to gender and hospitals. So 51% was male and 84% was from the public sector. Then looking at the results of the outcomes of malnutrition diagnosis according to the GLIM criteria, just looking at each of the parameters under the phenotypic and etiological criteria. So firstly, under the phenotypic criteria, 39% had a low BMI, and that is according to the GLIM criteria cutoff. 59% had significant weight loss, and 30% had a low muscle mass. On the etiological side, 52% had inflammation, and 37% had a poor dietary intake. So for the diagnosis of malnutrition, at least one phenotypic and one etiologic criteria had to be present, and this then led to 54% of the study population being diagnosed with malnutrition, of which 35% were classified as severely malnourished. As mentioned before, only 18% were referred to a dietitian. So that means that 82% of patients with malnutrition was undetected and untreated. So looking at the validation component, firstly, I'm going to talk you through MOAC as a surrogate for a low muscle mass. So looking at the correlation between these two variables, so it was a moderate correlation, as you can also see on the graph on your top right, with an R of 0.645. The area under the curve was 0.857, as you can see at the bottom on the right, which is considered good. So anything above 0.8 is considered to have good diagnostic accuracy. And from there, we determined the optimal cutoff on the optimal urine index, which was set at 24.9 centimeters. And that gave a corresponding sensitivity of 85% and a specificity of 74%, which was also good. And from a practical point of view in the clinical setting, to make it a bit easier to implement, it is proposed to round off this value to 25 centimeters. So below 25 centimeters for a MOAC would then identify a low muscle mass. For calf circumference, again, there was a moderate correlation found, again with a good area under the curve at 0.819, and the optimal cutoff value was determined at 29.1 centimeters. Just a reminder, should you use calf circumference to determine a low muscle mass, for patients that are overweight or obese, it is then recommended to adjust for a high BMI to minimize the impact of adiposity on those measurements. This cutoff also gave a good sensitivity and specificity of 73 and 83% respectively. And again, for practical purposes, it is proposed to round the value off to below 29 centimeters to identify a low muscle mass. Then looking at MOAC as a surrogate for a low measured BMI. As mentioned before, there's many challenges in the clinical setting to obtain a BMI relating to difficulty in obtaining weight and height, and many patients not being mobile. And here there was a strong positive correlation found with R 0.864, as you can see on the scatter plot there on your right. And the AUC under the ROC curve was almost perfect at 0.948, so very strong correlation and diagnostic accuracy to identify a low BMI. The optimal MOAC cutoff to identify low BMI, again, this is on the GLIM cutoff for a low BMI, and that was set at 26.3 centimeters and gave an excellent sensitivity of 91% and a specificity of 84%. And again, for practical reasons, the proposed value is 26 centimeters. So this is quite a busy slide, but I'm just going to talk you through the top row. And this is now the agreement between the original compared to the adapted GLIM. So the agreement of GLIM using the originally proposed tools, such as your measured muscle mass using the BIA, your measured BMI, and so forth, compared to punching in one of the surrogates in at a time. So for MOAC, comparing that to a MOAC of less than 24.9, comparing that with diagnosis of malnutrition using the measured low muscle mass under the phenotypic criteria, resulted in a very strong Cohen's kappa, very strong level of agreement at 0.925. And you can see just in terms of true positives and true negatives was there was very low discordance between these two methods, just with a bit of false positive, and that resulted in a 100% sensitivity and a 92% specificity. So this method diagnosed 58% of patients with malnutrition compared to, if you remember, the 54% using the original criteria. And then similarly for calf circumference, also a good agreement at 0.849 and MOAC at a cutoff of less than 26.3 centimeters, also at 0.854, all resulting in 100% sensitivity and high specificity of 84% for both of those values. So just putting that in the current proposed GLIM criteria, you can see with the red circle on your left, to just zoom in on the phenotypic criteria, specifically then for a low BMI. If that is not available, then the option of MOAC at the determined cutoff would be a valid substitute to be used. Similarly, with a low muscle mass, there you have two options, either a calf circumference of less than 29 centimeters or a MOAC of less than 25 centimeters to identify a low muscle mass. So in conclusion, both MOAC and calf circumference were supported as valid surrogates for a measured low skeletal muscle mass. MOAC was supported as a valid surrogate for a low BMI. And the use of surrogates may aid the implementation of a malnutrition diagnostic framework, such as the GLIM, in resource-limited settings. If that can be facilitated and implemented, that will lead to improved malnutrition detection rates, lead to providing the nutrition care, as Professor Blau highlighted, which we know from literature is associated with improved clinical outcomes and reduced costs. And with the added benefit that we could then, if it is done and information collected and used on a national database, can help to contribute to comparable local and global malnutrition prevalence data. And lastly, I would just like to give some acknowledgement. Very special thanks to my supervisors, Prof. Blau and Prof. Venold. She is from Pretoria University. Statistician Prof. Estrasen, for all her time and expertise in the quite complicated steps that had to be carried out. She was of great help. And then my field workers, as well as the funders from the NRA Tuka and the Harry Crossley Foundation. And so that's the end of my presentation. Thank you very much.
Thank you, Esmerie. You can stop sharing and then we can see the chat. So thank you to both Esmerie and Janneke for sharing your results of your research. And colleagues, everybody online, I hope you were caught up in our enthusiasm and our passion for this topic. And hopefully you can also see how all the smaller pieces of the puzzle fit together in trying to create a better solution, but also, as Janneke mentioned, we are really trying to add to the evidence-based. And I think the days of blaming the fact that there aren't enough local data available is long gone. We've got data. We now have to move over to the next phase and maybe use a lot of the tips that Janneke and her study participants gave us in terms of how to address this and how to tackle it in terms of contacting the powers that be and do education and whatever needs to be done. So I'm going to open it up so thank you to everybody for sticking to the time. We're actually well in time. I'm going to open up the discussion. So you can either please raise your hand and ask a question, or you can pop it in the chat box. If there's anybody that would like to either ask a question or maybe just share a comment or a thought in terms of maybe what you thought of the research, the practical application, the usability of the research, anything that you would like to add or ask. So I'm not seeing anything. So maybe Janneke, both you and Esmerie, while we hope to get a question or two from the audience. Next steps. I think, Janneke, you mentioned that we have been in chats, in conversations with some people, but if you had this magic wand that you could use to get your work out there and to change practice, what do you think one or two things that can be done for all of us to improve the situation?
Sure, Renee, that's the most complicated question of all.
Yes.
I would also love to hear from the audience about that. But I think the nice part of my study is the final phase was where we put together those strategies. And what I did not report on today is that the expert panel actually put actionable steps in place, how they see we can take that forward. So I would love to see some of those basic things just getting into practice. And as I said, also systematically doing it, deciding on one or two things and starting with that and getting the process rolling. Key thing is to get the key people on board, role players. So we need to continue with our dissemination of information. We need to get a talking point at various meetings and engage with people, because we need to get people on board to be able, we can't do it on our own. So we need to get everyone on board to take it further. But the suggestions from my panel included a lot of things, including education, training, engagements. There's a lot of steps that can be taken. But we need to, start somewhere.
Start somewhere. And I think, Esme,
Yes.
I'll come to you now. I was just thinking I should have mentioned it at the start, and I can't even say it was planned like this, but it actually happened like this, that this webinar of ours is happening in the middle of International Malnutrition Week.
Oh, fantastic.
So this is absolutely, so maybe I should say we planned it like this, but this is International Malnutrition Week. And if I can do a little bit of promo for SASPN, we have a malnutrition symposium on Saturday morning, also just talking a little bit more about this topic, and having Prof. Sederholm as to be the father of GLIM, that will also do a presentation. But I think the bottom line is, what are we doing? And you mentioned quite a few things, Janneke, that sort of caught my attention, and one of them was visibility. Mm-hmm. And yes, visibility does create more work, and more work creates another set of challenges in terms of, if I don't have the resources, if I've identified a patient to have malnutrition, but I don't have the resources to adequately manage them, it sort of leaves me in a bit of an ethical dilemma. But again, if we don't start somewhere, and if we are not visible, then maybe the powers that be will also not know about what is really going on. And, you know, we had a conversation with a colleague from Brazil the other day, and we were trying to organize a meeting during this week. And she was saying, but where in the world do you have time to organize a meeting this week? Because we've got so much planned every day on our calendar for Malnutrition Week. And then I thought, we are lacking with that in South Africa.
Yes,
you know, we don't have actions like we normally have with Breastfeeding Week or some of the other weeks. So visibility. But yes, it all takes money. Well, more than that, it takes human resources and it takes time. Esme,
absolutely.
Do you want to add?
Thank you. Yes, I think so many valuable information came out from Janneke's study, really food for thought on how, you know, just start a conversation. You know, I was thinking, for instance, and also Janneke mentioned that is, you know, we should collaborate with other healthcare professionals. You know, it's good that we start in dietetics, and you know, we've started in the nutrition society to talk about it, but we should also have this conversation with other healthcare professionals, especially the frontline care workers such as your nurses and your doctors, and look at the scope of practice. I know in nursing, for instance, there was more specific nutrition actions previously, which has been reduced in the last documents that I've looked at. So we need to look at those things, clarify roles and responsibilities, or just how we can work together, and yeah, just start somewhere. And definitely increase awareness, increase education. As Janneke has mentioned, some of the younger healthcare professionals seem to be more aware. Whether it might be related to training is a possibility, but I definitely think that is an important component. And also patient empowerment. I think patients, especially linking it to the right to nutritional care, patients need to be aware of that right. And we need to get the message out there.
That is so true, because I mean, from a legal point of view, the patient has the right. And I think, to me, it's also scary that the human right of nutrition care is not that well known, and it's definitely not yet implemented all over. So we do run a risk that we will be on the receiving end of actions that was definitely not intended. So I think many things to talk about, but again, from what you were saying, the one thing that I picked up on was, again, and I think Janneke also mentioned that, is having a champion, having somebody in any institution that is so passionate about it and that will drive it, that person that will niggle and bother and hassle and whatever you until you do something. And having one champion to drive this process will snowball potentially and take it further, and not sort of passing the buck, because I mean, that is one of the biggest barriers of screening, is whose job is it, who should do it, and it should be part of routine. First question, hi, how are you, sort of like, what is your weight, type of thing. You know, it should be part of record keeping. And then the system should flag those patients that require adequate attention. And maybe moving into the new national health dispensation that we are moving into, now is the time to have those talks and to ensure that proper nutrition screening and nutrition care is part of the plan, and it's built into the electronic health records. Because those are the facilities where it's part of the health records that we know from chatting to dietitians amongst the country. In those hospitals where it's part, it immediately works because the system flags the patient that needs further attention. And I mean, this is the tip of the iceberg in terms of requiring attention for treatment. But I mean, we have to start somewhere. Yeah, so colleagues Janneke and Esme and I can go on forever, so we're not going to do this if there aren't any questions. I'm just following on and making sure that there's nothing that's coming through in the chat. Doesn't seem like it. So then I guess it is for me to say thank you for those of you that have attended. We really hope that we've shared a little bit, as I say, of our passion, and that you will keep an eye out for the work that we're doing and supporting us where we can. And then Chanel, thanks to you for arrangements, and just a reminder for everybody to complete the link if you would like to get your CPD points. And then also the little bit of marketing for the recording and for some from also future webinars that Chanel has given the link. Okay, well, that's it. Thank you so much, everybody. Have a good afternoon and all the best. Thank you. Bye.